what does your workup look like, or like what does your referral look like, and then what does the workup kind of look like?
Yeah, so basically our referrals are generally coming from ER doctors. So generally what they call me after seeing, I mean, it doesn't even have to be bilateral PE or saddle. It's just a PE, and actually ends up being interventional radiology, vascular surgery, and interventional cardiology that takes call for PEs. So, somebody's on call every day. So basically when we get the call, usually my big criteria that I'll ask the ER doctor for, number one, especially if it's a larger burden thrombus or a saddle, I'll ask for a stat echo. And that is very helpful just for me to help plan the procedure. And I'll kind of go into a little bit more about why that is. But troponin, proBNP, and lactate, these are all really key things that I think should be obtained for each PE patient, because I just think it sort of helps you risk stratify them a little bit further. If you have somebody who comes in with an intermediate risk PE, but their lactate is 5 or 6, you know that this is something you're probably not going to want to sit on for too long. So I would say, in addition to the CTA, those lab values, obviously you're going to look at the patient's vitals, and then an echo is really key along with a venous duplex.
Okay. Ripal, same question. Similar workup. Like, how does yours differ?
We're pretty similar in terms of workup. We get imaging, we get an echo, we get biomarkers, troponin, proBNP, and lactic acid, and we kind of go from there. And obviously, the most critical thing initially is, is this patient high risk, or are we looking at an intermediate risk patient? As our kind of treatment algorithm will differ on the basis of how sick they are.
All right, so you have all the you kind of touched on it, Ripal, and that's the kind of the crux of what I'm trying to get into. Will you talk about how you stratify the patients, and once we do stratification, we'll kind of mean what that means for your decision algorithm?
Sure. Yeah, we typically utilize the European Society of Cardiology, the ESC classification, really stratifying patients into high risk. These are the patients that are either hemodynamically unstable on pressors, probably represents about 5% of the total patient population. A low risk, these are the normotensive patients, what I would consider a garden variety PE. And then the patients at intermediate risk, which, depending on the statistics that you look at, constitute at least a third of patients, maybe even up to 50%. These are patients who are normotensive, but have evidence of right heart strain. And whether seen on a CT or whether seen on an echo, with or without elevated biomarkers. And we further risk stratify them or subcategorize them into intermediate high risk, in which they have both imaging evidence of right heart strain as well as elevated biomarkers, or just one or the other, which is intermediate low risk.
Got it. Zarina, any differences there, or pretty standard?
Oh, pretty standard, yep.
Depending on how you stratify your patient, will you talk about what that means for what you're going to do with the patient next? How the treatment algorithm flows from that stratification? We'll go with Zarina.
Yeah. So, I think especially this intermediate risk group, they can be a little bit deceiving at times. I remember I just had a patient recently who they were admitted, stable blood pressure on a couple liters, but then these patients can drastically deteriorate fairly quickly depending on how much thrombus there is. So especially as a cardiologist, I rely a lot on echoes, and an echo can really sort of give you an indicator of what you're about to get into. So generally when I start the case, I like to know what their RV pressures are, and you can get a fairly cursory understanding of that from the echo. So if I see that their RV pressure is upwards of 60, I know that, I'm potentially going to need some backup. And it makes me basically, when I go in to actually do my right heart cath and get my opening PA pressure, if I see a number upwards of 70, I'm going to be really hesitant to start the case without some sort of backup plan in place. And so what I mean by that is, in some institutions, this might sound a little bit aggressive, but we have gotten into situations where we actually start doing thrombectomy in these patients, and they deteriorate fast. And if you lose a pulse in that situation and you start CPR is not going to be doing too much for them, unfortunately, because you have no gas exchange taking place because of all that clot in the lungs. So whenever I see PA pressures upwards of 70 or 65 even, where I'm calling my ICU team, the ECMO team, just to say, hey, we need to have you on standby just in case we need to cannulate before or up front even. And we've had really good outcomes actually doing that. So I think if you're nervous about a case, and I think that the echo is a really key part of this. CT scans, it can be a little bit deceiving in terms of RV strain or not, but an echo, you can tell if the RV is blown out and how high the pressures are, and you should, it just helps to prevent any surprises. So.
Okay. Ripal, same question, and like how that risk stratification works towards what you're going to do in the cath lab, or even if you take them to the lab.
Yeah, so specifically for the intermediate risk group, we tend to intervene on the majority of the intermediate high risk group patients, and that's mainly driven by probably two things. One is we've instituted this program now for many years, and in fact, as we're trying to enroll patients in PE track trial, for example, which randomizes patients to anticoagulation, we're actually getting pushed back the other way. Only anticoagulate this patient. It's just because it's been driven by years of success and very few complications, and patients are doing well. But really, at our institution, we really try to put everybody in a clinical trial, and so specifically for the intermediate high risk. The intermediate low risk PE patients, most of them we will anticoagulate alone. But one of the things, as we're training our residents and fellows, I always tell them, hey, listen, have you laid eyes on the patient? What do they look like? Maybe they're fine while they're sitting in bed at rest. But once we have them walking, and we do a walk test on everybody, or even when they're walking over to the bathroom, they become tachycardic, short of breath, desat. These are patients that might be at risk of decompensation, and those are patients that we'll consider treating as well. Now, obviously, when we're looking at the high-risk patients, these are patients that have a very high mortality in the range of about 30%. So these patients, nobody's going to argue that they need treatment. In terms of what is the right treatment, I think it's something that is still debated. But, we tend to risk stratify these patients into what I would consider be catastrophic high risk. These are patients that are dying in front of you. And if they don't have any contraindications, we'll give them TPA. And then we have the so-called, stable high risk patients. Maybe they're on one pressor, but they're doing okay. They look fine. And these are patients that we'll seriously consider bringing to the lab for a large bore mechanical thrombectomy.